Good evening, everyone. And it gives me my great pleasure to welcome everyone online tonight to our webinar on tonight's topic, which is navigating newborn and infant RSV immunisation in general practice, an Australian perspective. My name is Professor Peter Richmond. I'm a paediatrician and paediatric immunologist at Perth Children's Hospital, and I'm an immunisation researcher at the University of Western Australia and the Kids Research Institute here in Perth in WA. And I'm really delighted to be the chair of this meeting tonight, which is a really important topic dear to my heart of RSV immunisation in babies and young infants, and to really discuss the different sorts of scenarios that healthcare professionals and immunisation providers may face when we need to consider this in different states and regions of Australia. But first, before I start, I'd really like to acknowledge the acknowledgement of country. In the spirit of reconciliation, the Immunisation Coalition, myself and our speakers, acknowledge the traditional custodians on the various lands in which we work, particularly the Whadjuk people of the Noongar Nation here in Perth, where I am from. And I also would like to pay my respects to elders past, present and future. And would like to celebrate the diversity of Aboriginal peoples across Australia and their ongoing culture and connections to the various lands across this country. We're here tonight. We've got a fabulous multidisciplinary group of experts to discuss RSV immunisation in babies and young children, and the potential different patient scenarios that you might face, particularly in general practice and in other clinical settings. So tonight, we really want to cover the following areas. Just remind everyone of the epidemiology and disease burden of RSV in infants and young children in Australia, summarise the maternal RSV immunisation program that exists and the immunisation programs for newborns and babies and eligible children up to 2 years of age, which is part of our hybrid program that we have here in Australia, to really consider those different patient scenarios that you might come across in different states and territories. And finally, to what we can do for babies and infants that have missed their immunisations or their mothers have, and what processes are in place for catch-up programs. So tonight we've got 3 healthcare professionals who have kindly offered to share their knowledge and experience on RSV disease and immunisation in babies and infants. Firstly, Sarah Chu is a Brisbane-based GP and travel medicine director and honorary treasurer for the Australian College of Tropical Medicine and member of the Immunisation Coalition. Welcome, Sarah. Our next panellist is Dr. Leon Levitt, who's an experienced general practitioner and obstetrician from here in Perth and is the director and founder of Baby Steps Health Centre in Perth. Dr. Levitt has consulted in family medicine in Wembley for over 30 years and is very experienced in the care of infants, mothers, children, parenting and general practice procedures. And he founded the Baby Steps Health Centre to enhance the delivery of services to young mothers of Western Australia. He's very active in the community and takes part in numerous charities that I won't mention today. Welcome, Leon.
Thank you.
And rounding up the group is Priscilla Singh, who is a registered midwife and nurse consultant in infection prevention and control, who is an executive committee member on the Immunisation Nurse Special Interest Group and actively immunises for her council every year. She continues to contribute to research governance through her services on research ethics committees, including those at Monash University and St John of God Healthcare. Priscilla was recently awarded the Australasian College of Infection Prevention and Control Impact of the Year Award, and just last month, the prestigious Certified Infection Control Professional Expert Certification. And if that's not enough, she's also currently undertaking a PhD to further expertise and commitment to infection control and prevention. Welcome, Priscilla.
Thank you. Thanks for having me.
So just to remind everyone tonight that we will be taking online questions and we'll try and endeavour to answer all of them. So this is going to be an interactive session. So please use the Q&A function on the webinar, and we will do our best to answer as many questions as possible during this evening. But also, we will any that we don't get to, we would like to get back to you after the webinar, and that will be provided on the site at the end, which we'll talk about. And finally, we would like to acknowledge Sanofi, who are supporting this educational activity. So let's start. So as a paediatrician, I'm well aware that RSV is the most common reason that young infants in Australia are hospitalised in their first 6 months of life. And we estimate that there is probably 10,000 hospitalisations due to RSV in Australia each year. And this is the highest incidence is those children under 6 months of age. And so this is a really important condition that causes a lot of trauma and morbidity to children and their families. And so I think it's really important that we do everything we can do to prevent this occurring. And not only is it an important cause of hospitalisation, but we also know that RSV can cause long-term complications in terms of susceptibility to chest infections and recurrent wheezing illnesses throughout preschool children. So this is something that we now have the opportunity to prevent. But I work in a hospital and it's quite different to general practice. So Leon, would you like to sort of tell us from a general practice perspective what RSV means to you as a clinician and the families you serve?
Thanks, Peter. The RSV in the community is a cold. So the majority of people that we see with RSV will have the typical cold symptoms of runny nose and sore throat and cough and complications with ear infections and chest infections, etc. But it can progress very quickly in the young ones. And so the incidence in the community is so skewed towards the under 3-4 months of age that we've got to be really diligent. And the reality is, in general practice, we're very diligent about any fever and illness in a baby under the age of 4 months. And really, you've got to have an extremely good reason not to go and do a full septic screen on such tiny little babies. But we're seeing lots and lots of colds of multitude of viruses, and the RSV is just one of them. But only yesterday I had a severe case which is proven to be RSV with a really nasty bronchiolitis requiring admission.
Yeah, thanks. So, and that's really important. And I think really that that sort of progression of disease, which really we can't do anything about, is really traumatic for families, and parents do get very anxious. And unfortunately, as RSV occurs during the wintertime when we have all these other viruses, it also means that patients are waiting in hospital for a long time before they get seen. There's bed block in the hospital. And so it's really has been quite traumatic. So I think we are all, as health professionals, committed to trying to reduce this burden. But I think in Australia, we have actually had some experience in preventing RSV. And Sarah, Queensland, with Western Australia, was one of the 2 states that had a universal immunisation program with nirsevimab last year. Do you want to sort of tell us about the experiences that you had in terms of that program and perhaps the impact that you were able to see from your perspective?
I'm really pleased to report the rollout was a little bit more smooth compared to COVID vaccinations rollout. We had a lot more notice in advance, so we were much better prepared. And I think our patients weren't surprised. We weren't surprised in finding out from the news, hearing from our patients who saw it on Facebook or ABC News. So it was really lovely to see the program roll out with nirsevimab starting in April or so. In fact, my boss had just delivered, his wife had just delivered twin girls, and they were one of the first ones on that very first day to receive their Beyfortus in hospital. We didn't get a Brisvo until this year, but last year the take-up was incredibly well received by a lot of parents. I think they had, although they may not have heard specifically about what RSV was, they could understand what a child with bronchiolitis, what that would mean. The difficulty feeding, staying up, being worried about whether they'd need to go to hospital, trouble breathing through their nose, difficulty sleeping, staying upright, having them sleep on their shoulders, and, just really, really worried parents. So we had a reasonably positive uptake, especially when we consider this was in the year or two right after the COVID vaccinations, which made people lose a bit of confidence and added to the challenge. And I guess in summary this year, yes, echoing Leo's sentiments, we still see a lot of the winter colds, and it's a bit of a mixed bag with what's coming through the door. But really nice to see recently in the MJA, just in June last month, that they've reported that in Queensland that there was a 69% reduction in the hospitalisations among infants that were under the age of 6 months as a result of this program.
Yeah, that's great, and what a fantastic thing to be able to do for families. And I think, as you said, it's and Leon mentioned it is a common problem seeing children with RSV in general practice, and I think there's almost 5 times as many people seeing their GP in general practice for RSV as those hospitalisations. So it's really something almost affecting 1 in 10 young babies who are under 6 months of age during this RSV season. Leon, Perth had a similar program, although there were some differences to Queensland. What were the learnings that you took away from last year's program in WA with nirsevimab immunisation?
My experience was that people were very enthusiastic, and also it depends on the enthusiasm which you put to the selling of it and explaining what it is. I think they were happy that it was to understand the nature of the vaccine, that it's a vaccine of antibodies rather than of antigens, and understand that process, and that it was going to cover the child for the winter. I think at the same time in Western Australia, the uptake of Abrismo has been pretty good, and we're finding even in this last few weeks that the number of patients that we are contacting who come into our rooms have already had both the maternal vaccine or the child vaccine, that is much greater than it was last year. Last year, as I understand it, Western Australia had an 80% reduction in hospital admissions and a 90% reduction in ICU admissions. So it was pretty effective. I mean, that's a total game changer, really, for RSV. This year's statistics, Peter, you might be able to comment on better, but from last year's experience, it's a no-brainer for us to be trying to perpetuate it.
Yeah, thanks, Leon. And I think one of the surprises for me last year with the immunisation is how high the uptake was for those newborn infants who were born during the RSV season. And I think we actually had really great support from midwives in the maternity hospitals. And, you know, I think that's something that's really important to acknowledge, that with pregnant mums, midwives and the nurses who are looking after them are really important in getting their babies immunised. Priscilla, do you want to sort of comment on getting babies immunised in that sort of immediate neonatal period?
Yes, definitely we are in the best place to offer the RSV vaccine for our little babies. Our conversations begin antenatally with the bubbers, mums, and the families. We discuss the Hep B that we're going to give after birth, vitamin K, and now we've got the RSV also added to that conversation. So I think it's very ideal location and timely to, speak to the parents about what's available. And then we do the 28 to 32 week antenatal appointment. We can discuss the whooping cough, the flu, and offer RSV for the mums too. So we are in prime location for offering these RSV vaccines and immunisations for both cohorts.
Yes, fantastic. And that's right. So that's the big change this year. So not only do we have a licensed RSV immunisation as nirsevimab or Beyfortus for babies that's been funded by the states, but we now also have Abrismo, the maternal vaccination for all mums across Australia all year round. So, Sarah, do you want to talk a little bit about some of the differences that might occur with some of these programs across Australia? Because I think we have people dialing in from everywhere.
Absolutely. I'm based in Queensland. Priscilla's in Melbourne. Leon and Peter, yourself, you're in WA. And I apologise to all the attendees because it is so complex depending where you are. And I hope you're not working in 2 or 3 states locuming because it's quite difficult to get your head around it. The simplest way, hopefully, just to try to help you, I guess, have some take-home messages when you leave this webinar is always try to have that discussion when the mothers are pregnant, because it simplifies things so much more to give a maternal vaccination to the mother. And we've got the additional benefits of protecting mum as well and having her pass through the protective antibodies through the placental transfer as well. And the baby is protected from day one. However, so NIP funded as of earlier this year, and given, as Priscilla's already alluded to, from 28 weeks, ideally before 36 weeks. So we have at least 2 weeks before the baby is delivered to make sure she's produced enough of the antibodies and they've crossed over and baby is born with enough. I want you to think about what conditions mum might have that may mean we don't get optimal transfer of the antibodies. And it might be if mum is immunosuppressed or she's taking medications that suppress her immune system and she might not make as much or be able to transfer it to the baby. Or if mum has had things like ECMO or procedures that may have, again, reduced the antibody production and transfer to the baby. Another big one is if mum has not had the vaccine at least 2 weeks before the baby arrives, then you have a reason to have a look at giving nirsevimab Beyfortus to protect the baby a little bit better. So I always start, I guess, with the maternal vaccination, but as part of the whole conversation, I guess we talk about vaccine choice, and some people may not want to have the maternal vaccine, and they may opt for nirsevimab Beyfortus when the baby is born instead. So a lot of the key things that are common across the whole states and territories are that we fund it for most of the babies and infants are all eligible to receive it at birth if mum has not had a Brisvo, the maternal vaccine, if she's not had it at least 2 weeks before, if mum has a condition that again suppresses her immune system, or if the baby has high risk conditions, that means that they are at increased risk of having RSV and complications. And there's about 7 of those risk factors that are common across Australia. I can list them out and I might just do that quickly. So, but there's going to be lots of resources we'll put up on the link so that you'll be able to refer to it. So a lot of those conditions are going to be babies that are born. So the first one, babies that are born preterm before 32 weeks. Then the next one would be the ones that might have a hemodynamically significant congenital cardiac disease. And it makes sense because these are all conditions that put the baby at increased risk. If the baby has immunosuppression or medications that suppress their immune system, or they're undergoing transplant or have severe immunodeficiency, lung disease, cystic fibrosis, neurological conditions, again, that mean that they might need respiratory support, oxygen, or their lungs aren't working as well or makes them more vulnerable. And sometimes if you're working in conjunction with a pediatric infectious diseases specialist, they will advise as well if the baby will need additional Beyfortus as well, and babies who have trisomy 21. So these at-risk conditions means that irrespective of what mum's had, the baby still will be eligible and recommended to receive Beyfortus. Now, across the different states and territories, timing, some places where I'm lucky enough to work in Queensland, Northern Territory, New South Wales, ACT, it doesn't matter when. It's not seasonal. I don't know whether we just have good funding and we don't have to think about things, but some of the other states like South Australia, Tasmania, Victoria, WA, it's a bit more seasonal, and it might also reflect where we want to best spend our money to target when the seasons are worse. So it's typically newborns and infants that are born between 1st of April or this year up until September, 30th of September, that we're really targeting Beyfortus for that particular group. There's a lot of subtle differences, and that's just the newborn cohort and the infants up to 6 to 8 months, depending where you are, because they're the youngest and usually the most vulnerable. And then it's going to be a little bit different if we're looking at the infants that, again, have high risk factors, the at-risk medical conditions we've talked about, or in WA, some of the ones that Aboriginal and Torres Strait Islander babies, if they're going into their 2nd season, then there's the good thing is, although it might be very complex, I've had a look, and most of the ones that are a bit more complex, there are adapted flowcharts for each state where it is a bit more seasonal and it's a bit tricky to navigate. I might stop there just because I don't want to go into too many details, and I'll throw that back to you, and I'll keep an eye on the questions that are coming through the audience.
Yeah, thanks, Sarah. That's great. That was a very comprehensive. And I think the message is that it does differ between states, and the best source will be your public health departments or your primary health alliances that surprise you with information regarding immunisation. So I think that's really important. Leon,
to make it easy,
yes.
just to make it easy, the Immunisation Coalition, if you search under diseases RSV, there's a tab and it will take you to all the states and territories. And if you click through the links, we'll have it linked through later on in the webinar resources. It's a fantastic summary if you want to have a look through everything. Yeah. I know there's some questions that are coming through, and I might even just jump in and answer that now because it might flow quite well with what Catherine Wilson and Carolyn Bray have asked about. And if you go through to the web, to the Victorian resources, same as Queensland. So the dosing with the weight for whether they're under 5 kilos or over 5 kilos really only applies to the first infants, newborns, first season. If they're in the 2nd season, if they're over 8 months, it's basically the same 200 milligram dosing that I can see in the Queensland guidelines that we follow, and also in the Victorian ones as well. But we'll come back to more questions and answers later on.
Thanks, Sarah. That's great. Yeah, and the dosing is the same for all the states, so that's important to remember. So under 5 kilos, 50 milligrams. Over 5 kilos in that first RSV season, that's 100, and then the second RSV season, that's 200, regardless of their age or weight. So, so I guess you've mentioned that we need to start this discussion during pregnancy. Priscilla, from your point of view, how do you approach these pregnant mums when you're talking about immunisation?
Well, we have the open-ended, questions and discussion. I think it has to just be factual. We do discuss, the burden of disease at the time. So, summer season's a bit different to the winter season, but still there's the burden that, you want to protect the mums and their babies and the ideal time to have the vaccination. Most, when women find out when they're pregnant, they actually go to their GP. So first point of call to get that pregnancy test, to get the first ultrasound and everything like that. I think it's ideal to just start those conversations right then and there. So it's not so new to them. Most of them come to see us at their 28, 32-week appointment or when they're, in labor and giving birth. So then we have the consent forms and we did have the discussion then. But yeah, definitely should start quite early on in the picture, I think. And the more now, because in Victoria we are in our infancy stage, I guess that's the pun. So we will learn from our states and territories that are in their second season and look at how the rollout was there and now that the nirsevimab is available for the babies, if there is that need for it. We've got the 60% uptake here, and what we would decide, I guess, is whether there is that need for the 40%, what is required education-wise, rollout-wise. We do a lot of catch-ups in the community for our local council as well. So that's another niche that we can vaccinate our babies when they come for their 6-week, 4-month, 6-month, vaccinations too. So I'm not forgetting our little council workers out there too.
No, thank you. That's really important. And I think you brought up a good issue, because if you are perhaps seeing somebody for the first time at 6 weeks, you really need to try and work out whether or not the mum has been vaccinated, and if they haven't, then inquire whether the baby has been immunised during that neonatal period. But it's not always easy, Leon. How do you approach it in your sort of practice when you're seeing a baby coming in for their 6-week immunisation at the moment?
Well, if you think about it, the 6 week is already halfway through the danger period already for the child, because most of the dangerous results and admissions come in that first 3 months. So I'd be emphasising the midwifery component, the antenatal clinics and the obstetricians as the primary source, because then they're covered from day one. But the GP, in our clinic, we see a lot of babies in the first few weeks with breastfeeding problems, etc. So we'll try to have a discussion then. But most GPs are seeing them at the 6-week check. And at the 6-week check, then the key to a GP's practice and diligence is not the GP, is the nurse. I'll trust my nurse to be diligent with the immunisations much more so than the GP. So if we empower our nurses to talk about it, give them the information and get them to encourage the parents both to, first of all, give us the information whether the mother had it, whether the baby had it in the hospital, and then start the conversation, the GP's work is done, because the nurses, and the same in the antenatal obstetric clinics, it's the nurses who are going to do a better job, I'm afraid, than the doctors. But we have to empower them to have those conversations.
Yeah, fantastic. And I think there's a lot of those nurses are actually on this call tonight, so they're obviously very interested. So I guess we can, there's various ways we can check the immunisation status for the mother and hopefully also for the baby, although it sometimes doesn't always work as smoothly as it should. So things...
No, so we'll check the purple book and to see have they had it in hospital, and we'll check the immunisation register. But the hospital staff are very busy and they don't always complete it. But that's where we'll go. And then if we don't find it on the register, we don't find the purple book, and the mother's really not sure whether she had it or the baby had it, then we will err on the side of protecting the child and give the Beyfortus to the child.
Yeah, thanks. That's great. And I guess over time, it is also entered in AIR on the Australian Immunisation Register, both the mother and the baby's vaccination, but not in that first couple of weeks because they're still going through that registration process. So it can be tricky. And I think this is why we need to continue to make sure each time that the baby has been immunised. In fact, I had a child in hospital this week who was admitted who mum had not had the vaccine because she was sort of the vaccine was only just becoming available in February, and then saw her GP at about 10 days of age and was found to have influenza, and then had a chronic cough and was seen weekly, and nobody got around to asking about whether they had had nirsevimab or not and mum's vaccination status, and so unfortunately ended up in hospital. So that's exactly the situation we want to avoid. We want to make sure that that doesn't occur, and as you say, it's actually a team effort, isn't it? It's the obstetrician, it's the midwives, it's the nurses in primary care, it's the child health nurses, and it's the GPs and the paediatricians as well. I call in my colleagues here who sometimes see patients with these high-risk conditions and forget to talk about RSV. So I think that's really important. So
I think, Peter, the word is be opportunistic.
yes,
You've got to take every opportunity. You've got a baby with you and a mum with you, or an antenate with you. You just got to take that opportunity, and it doesn't matter if others have already had the question answered. It's a little bit like postnatal depression and anxiety. You've got to give every opportunity for the mother to be able to speak her mind, and you don't know when you're going to get that information. So the same with this program.
Yeah, no, that's great, and I think it's important to remember that the maternal vaccination and the neonatal immunisation, the Beyfortus, the Brisbane in the first instance, are different. So because one of the advantages of the Beyfortus is that because it's a passive immunisation, it doesn't actively stimulate the immune system like vaccines do. So that's why it's actually fine to give it, even if the baby's come in with a bit of a cough. You can provide them with the vaccination, with the immunisation, and it gives protection, from that night. They have protective antibodies in their system. So I think that's important. And obviously it's really important that we don't mix them up either, isn't it? So, it is tricky. We have RSV vaccines for older adults. We have a Brisvo for pregnant mums, and we have Beyfortus for the baby. So I think a Brisvo antenatal, Beyfortus baby. So because we have had a few cases where unfortunately the maternal vaccine has been given to a baby, and vice versa. The Beyfortus has been given to the pregnant mum, which is obviously a mistake. And I guess, what are the ways we can make sure those mistakes don't happen? Sarah, do you want to comment on how your practice handles that?
Absolutely. I spoke to my nurses last week about this, and they said, they had a very brief in-service from the Sanofi team, and they said it cleared everything up right up for them. And there's also some free education webinars and online courses you can do. Some of them, she said the nursing component one for her was only 20 minutes, but it was very clear. And we talked about maybe some memory hooks for the webinar attendees today in terms of, because we know that learning, if we can make it fun and maybe a little bit sort of quirky, it might be easier to remember. So RSV, the Rex, I just think of an older man, a retiree. RSV is for retirees, or at least for your boomer sort of population, an older sort of a group. But RSV, or Rex for King Charles, he's an older man. RSV would be for the older group. So definitely Rex, not a pregnant woman in that name. A Brisvo, a baby on board, a baby on the way, a Brisvo for the belly, a Brisvo for the bump, AB, antenatal bump, belly, whatever you want to sort of remember. And Beyfortus sounds like baby fortress. It's basically to build the baby's barrier. So whatever works for you, think of some fun memory hooks. And then that's in addition to your whole clinic policies, segregating things in the fridge, stickers, right patient, right product, right eligibility. But I'm keen to see what Priscilla might have as well, what other tips she has to share.
It's exactly what we do. 2 different fridges, a baby fridge, adult fridge, and 2 separate locations. So, the confusion is not right there in front of you. And I like that, a Brisbo AB for baby, mum, and then the nirsevimab for the baby. So
Yeah, that's great. Thanks for that. And Leon, what about you? I'm not sure you have room for different fridge for every patient group you provide vaccinations to. You're on.
Yeah, no, I think it comes down to basic principles of managing immunisations.
Yeah.
And that is you double check everything, and you have someone to check. There isn't a general practice in Australia that has not had a situation where they've given the wrong vaccine for something. And so it could easily happen in this case, especially if you've got a new nurse or you've got a new doctor or a part-time doctor who's not had the experience with this. And none of us have had huge experience with this particular vaccine regime. So I think it's just about diligence. And again, I always trust the nurses ahead of doctors.
Yeah. Yes, they're much better at following the rules, I think, is generally my experience in checking things. So I think it's on all of us to make sure that we make it clear what should be given to what babies. So I guess sometimes people get a little bit confused around if babies have been born before the mum has been able to get a vaccine. So before 1st of February this year, it was not available generally across Australia, although in Queensland may be slightly different. But what's your approach to giving nirsevimab to those babies? When do you sort of tend to sort of try and make sure that they have had their immunisations?
So in Western Australia,
yeah.
In Western Australia, the first thing I'll do is I'll ask, what's the baby's birth date?
Yeah.
Because if it was born before October the 1st of last year, then we can't give it.
Yeah.
So if we're born after the 1st of October, from the 1st of October, then the second question is, did the mum have it? And if she didn't have it, then did the baby get it in hospital? And then if there are any risk factors that might that means we've got to be more diligent on those scores. So I think it's just, you just got to go through a routine. You have this conversation with the families, and if they can't answer the questions and you can't find information on air or the purple book, and Western Australia it's the purple book, in New South Wales is the blue book, but whichever state you're in, you'll have your own coloured baby book.
We have green.
You just got to go through the steps.
Yes.
Yeah. Just got to go through the steps, I think, in order. And it's not a long conversation. It just has to be done diligently and each time, and you'll be able to say, yes, you slot in. And let's try and talk about its benefits for that mother and that baby.
Yeah. Okay, that's great. Thank you. We're getting lots of questions, so thank you. So we'll make sure we do try and answer all those questions about vaccination and immunisation. And in terms of the timing of immunisation, I think where we have had an episode, and I've had one patient this week, as I said, where the mother was vaccinated at 34 weeks, and then the baby was born at just before 36 weeks. So there wasn't quite that 2-week period. But unfortunately, when they were in the neonatal ward, I think people assumed that because she'd been vaccinated, they didn't administer the immunisation. And obviously, being born a little bit preterm also increases your risk. So I think it's really important in those contexts that we do try and get it right when you say about when did the mum get the immunisation and when was the baby's birth date, to make sure that 2-week is in that. So I think, and I think the other thing to be clear to everyone is that if you make a mistake and the mum actually couldn't remember and had been vaccinated, and you give the baby immunisation, it's not going to do any harm. So it just gives you a bit of extra protection. There's no interaction between the nirsevimab immunisation or mum being immunised. You just get more antibodies, and there's no evidence that there's any increased reaction. And actually, there's some studies going on to see whether that gives you higher levels of protection, which are already pretty good. So I think we're starting to get a few things coming through. So Caroline Bray has said, if a child requires a second RSV vaccination with a history of significant cardiac conditions, whose weight is only 6.5 kilograms, so this is a child in their second year of life, so they're still quite small, do they require 2 by 1 ml of 100 milligrams per ml, or because they're under 10 kilograms, only 100 milligrams or 1 ml vaccination, so 1 or 2 immunisations? So I think the recommendations for people, and I think Sarah explained this, for if you're in your second RSV season, the recommendation is to give 200 milligrams. If the mum is concerned, or you about in a small baby who's obviously failing to thrive because of their cardiac condition, we know from the studies that were done that actually 100 milligrams would give that baby protective antibody level. So I guess that is a context where there might be some discretion, but the recommendations are generally to try and make it easy, give everyone 200 milligrams in that second year of life. So now somebody said, and you might be able to answer this, Priscilla, I think it's from Victoria. The mum, there was a well baby who wasn't immunised, but mum wasn't immunised, even though the baby was born after January, but they can't order Beyfortus from the vaccine centre. I'm not quite sure why that might be. I know there has been some issues with supply and probably demand outstripping supply.
As a nurse immuniser for council, we're very opportunistic. We will vaccinate anyone who inquires about any vaccination. So it is quite disappointing when you do have to, I guess, send parents away, and you do feel like a failure from a nurse immuniser, perspective, saying that we don't have the vaccination when you've got the NIP schedule, when you've got the buy-in from the mum and the children are quite there, because it's very hard to go out with an infant, especially 6 weeks and at 4 months. And for that, we actually had said no to a patient last week in council, twins, who came in for their vaccination because we only had a short amount of stock. And so I think even though they are saying that the supply is quite fruitful or available, we are still seeing shortages, maybe not in birthing hospitals, but definitely more in the community settings. We are seeing that the supply is quite limited. So we are having to, say no to some parents because we just don't have the supply, which is a shame. And then we ask them to go to their GP. So there you go.
Yeah, I think that's very difficult, but hopefully the GP will have the supplies. But I guess in general practice, I guess we generally make sure, Sarah, that we sort of, if we know somebody's coming in, we've got an immunisation to give them if they've been booked in and for an RSV vaccine, an immunisation.
Absolutely. I'm very lucky. My nursing team is fantastic. So we can see what our reception staff pop in. Are they 6 weeks, 4 months, 6 months? And so we'll have an idea whether there's anything missing. And my boss has a lot of clinics. So we've even had times where we've borrowed some from a clinic down the road. That's our sister clinic, owned by the same company. So we try our very best to make sure that newborn parents are not running around any more than necessary, because it's very stressful to leave the house when you've just had a child. But yes, certainly the supply issues that we've, speaking to colleagues around the country, it really varies and it depends on luck sometimes.
Yeah, no, that's right. Well, hopefully that's not an ongoing issue. Amanda Nash has also asked about if a well baby who was born in December 2024 comes to you and so mum wasn't able to be vaccinated and the child hasn't been immunised, and was coming to yesterday or today, what would your approach be if they're just well and they don't have any risk factors?
So I wasn't sure where Amanda is from.
Also, I think Amanda, is from Victoria.
Victoria, yeah. So it really depends. In general, in Queensland where I am, we would have up to 8 months would be the general recommendation. It's not that it's dangerous to do it, it's just that that's when they're likely to be at the worst of the risk of their, the infections. I guess we're in the middle of RSV season, so it depends on your state's catch-up program and the eligibility. But for infants that were born basically from the 1st of October in Victoria specifically, if the mum did not get a Brisvo, and that's likely because it wasn't on the NIP, so unless you gave it privately, didn't receive it at least 2 weeks before the baby's born, baby hasn't had nirsevimab, if born in December or in July, so if they're still under 8 months, they would probably be eligible for a catch-up, and hopefully you can offer it in general practice or the council clinics, Aboriginal Health Services. So hopefully that will be a loophole that allows you to go for it.
Yeah, fantastic. And I think that's right. And there is still a risk for babies after 8 months, so it is worth it, even for its sort of 2 or 3 months to go in the RSV season. So we see lots of babies with bronchiolitis and pneumonia as well, actually, in those older age groups. So that's a really important one.
Probably segues into another nice question as well. What if a baby's had a RSV infection recently, and we know if they've recovered, they don't have a super high temperature, it's safe to give, because we know that having an infection doesn't give you long-lasting protection. It's like whooping cough, isn't it? You know, you catch it, you can get it again.
Right, unfortunately. So the risk is slightly low, but yeah, you're right. Yeah, there's no problems giving it if the child hasn't had it. So particularly if it's a very mild infection. And I guess there's also a question that maybe in answer for you, Leon, that not all states have a 6-week check. Victoria doesn't. I wasn't aware of that, actually. I didn't know GPs in Victoria. Is that right, Priscilla? Is that?
We do recommend it, but whether it's not mandated.
It's not mandatory, yes. Yeah. Okay. All right. But they can get immunised through a clinic as well, isn't it? It's 100%. Wherever they're getting their routine vaccines, they should be able to get Beyfortus.
You should be with the supply.
So there's also been a couple of questions about wouldn't RSV vaccines be on air or immunisations? Do you want to answer that one, Priscilla?
Yep. So we're mandated to report onto air. I presume all the states and territories are the same. So yeah, it's just, I guess, looking at manpower and time factor in our council setting, because our clientele's quite non-English speaking, that kind of thing. So we're very opportunistic when they come in. We ask, would you like the flu vaccine? Would you like? So it's more, just having the discussion with them when they come in.
And for those infants, about how long does it take to upload to air in your council setting?
Usually about 2 weeks.
Yeah, 2 weeks. So if they've been for a vaccination 2 weeks previously,
maximum, because
it's not on air, then they haven't had. Yeah, would that be a reasonable thing to say?
Yeah. Now that we've got all these new electronic reporting systems, the data usually feeds quite quickly, which is great.
Yeah.
I think we're very spoilt in general practice. Ours comes up pretty much immediately.
Yes,
so
exactly.
We use best practice, and they jump. They've got their little Medicare apps, and I see the parents tapping. They're like, "Oh, it's here!" So very quick.
Excellent. Yeah, and I think that's great. I mean, that's the joy of having a fully electronic system linked to air. So
I think a lot of the attendees will be familiar. A lot of the time, you're giving 2 vaccines, and air. I know most of us have probably had that experience where you can only enter 1 RSV vaccine, even though they might have had 2 needles. So we typically will just put in under the 1 RSV, but put the batches in for one of them and the other one in the free text section.
Yeah, that's great. So there is a question here about Aboriginal infants. Are they considered high risk? Do you want to take that one, Sarah?
I guess Leon will be able to answer that as well, but certainly in WA, I believe it's one of the criteria that makes you eligible for a Beyfortus boost, a second injection in the 2nd year of life. So it depends on your state and territory, but in general, it is recognised as a risk factor.
Yeah, that's right. I think it's at least twice the rate of hospitalisation as non-Aboriginal or Torres Strait Islander children. So I think that's really important to make sure that, and if we're having an acknowledgement of country, we have to acknowledge that they bear a high burden of RSV disease. So we need to make sure that we can vaccinate the mums or the infants if that's needed.
And that's also in the older population as well too. So exactly. Victoria, go Victoria. I don't follow AFL or the other sports, but they've just funded Arexvy, the vaccine for older people. If you're 60 and above, if you're in a residential care facility or an Aboriginal Torres Strait Islander controlled health service. So a bit of a win there for the other age group.
Yeah, fantastic. So we've got a couple of questions here about clinics ordering nirsevimab and the frequency of orders. Is anyone aware of how that works from a general practice or a clinic point of view?
From my perspective, early in the RSV season, we were running very hot with them, and so we established a relationship with the supplier of a weekly order, and that first week or so told us the volume. So I think if you're in a general practice where they're not really comfortable, haven't been comfortable pushing it because they didn't understand it. But after this webinar, you do understand it and you start to push it. Then at the end of a week of use, you want to then contact the supplier and say, look, we've just given 15 this week and we're going to be doing this for a while. Please, can you supply us? And we found once they had the evidence of us using it, then they were very obliging.
Yeah, and I would hope that would apply to most states, but I guess we are still a bit learning all about how to do this and not exactly knowing how many mums are going to be taking it up versus not taking it up. It has been tricky for everyone, I think. So, okay, so
Sorry, Peter, I do believe the birthing hospitals do have an enormous supply for the Nissimam, so
that's right. So that's another place.
point.
But and from your clinic point of view, it does vary a little bit
Mhm.
in terms of the ordering. But I think Leon's right. I think if you can demonstrate use, then you should be able to replace those, and that's really important. Now, this is a slightly tricky one. This is from Catherine Wilson. She said that if an infant presents at 6 weeks with small muscle mass, so skinny, and parents would like the NIP vaccines, Prevnar 13, Vexelis or Infanrec Hexa, meningococcal B vaccine, MenACW and RSV, what are we going to do? The thighs aren't sufficient, and how do you prioritise and what interval would there be? How would you approach that, Priscilla, if somebody came to your clinic and was saying, I want the lot?
Well, I guess it just depends on what the mum also would like. You know, if she wants a lot, and we look at the muscles, and we can use the arms and
Yep.
the thighs as well. So yeah, just having that discussion and whether she can come back on another time if she really, you know, if they are quite small muscled as well. But
Yeah.
also, you know, being opportunistic and trying to get as much in as possible is also ideal for us.
Yeah, I think so. And I would say if you are going to have to drop one of those vaccines, RSV would not be the one that I would not give. That's meningococcal ACWI is really about longer term protection, and we don't really have much of it in young babies under 12 months. So I would definitely say RSV, of all those great vaccines we provide free for all these babies, RSV is the one that's most likely to cause them to end in hospital. So that would be another thing to think about if you're trying to say, or you can come back. But certainly you can give the Beyfortus as soon as possible after immunisations. The next day is fine. There's no interaction. It's not like other vaccines where we normally talk about 2 weeks, but if you have a fever at that day, it's usually due to the vaccines, not the immunisation, Beyfortus. So, and vice versa. If the baby's had Beyfortus yesterday, you can go and give them all their routine immunisation. So I think that's really important to be aware of. So I think we are, so there's some differences. We're hearing from somebody in New South Wales, every order's individual for the baby and is not kept as stock in practice. So that makes it a bit tricky. There's one question here I might answer around if your child was born in October 2023 and doesn't have any risk factors, can they get a RSV vaccine? The answer is no. So if you're over 2, there's no vaccines available. The amount of antibody in Beyfortus doesn't give enough protection to older children, and actually hasn't been studied over 2 years of age. And it's not supplied by the state, and so you can't get it privately. There are some studies going on looking for a toddler RSV vaccine, so watch this space. Maybe we'll be talking about that in 2 years' time. One is actually a nasal spray vaccine, which would be nice for babies, I think. So, but we'll just have to wait and see about that, I think. So I think we've covered most of those things. What about the issue of where the mum's hesitant? So she's not saying I don't want to have it. She's just saying, look, I'm a bit worried. This is all a bit new for me. How do we approach that? How do you guys approach that? Because I think that is something, and I think COVID's probably brought a more shine of attention onto vaccine hesitancy. Who wants to take that one?
This morning, I had a patient who's a Russian woman, been in Australia about 3 years, and the Russian people are used to the state doing things that may not make sense or be appropriate, and they're not trustworthy, so not trusting.
Yes.
So this baby was 4 months, and she wanted a few things done, including the immunisations, but she would not take this one. This is all new, and so I'm arranging for her to come back in another week or two, and we'll have another discussion, because there are other issues that I can create with that child to follow up on, and weight gain, etc.
Yeah.
But I think in the first place, it's time.
Yeah.
Often parents, the same applies to the flu vaccine. It's not routinely taken up by every 6-month-old baby's parents, and it takes a bit of discussion. And if you meet their concerns, the nurses and the GPs, then I think you can move them around. And sometimes you just have to say, well, okay, we'll do the Beyfortus this week, and we'll do the 6-week check ones in next week, and find out what makes them comfortable in order to get the right outcome for their baby.
Yeah, I think that's great. And I think it is something we as health providers need to be very confident in our dealing with these families, isn't it?
Yeah.
Sarah, do you want to make a comment? Or
I think about 3/4 of the patients are really going to take up vaccines, and they're not really anti-vaxxers. They're more either, life gets in the way, they're busy, they might have some questions and concerns, which are very valid. So I find our healthcare providers' recommendation, we know it's the single most important determinant of whether they will take up a vaccine or not. Spend a lot of time on the ones that are in the middle, that have questions, that are more fence sitters. But I would say that having that trust and rapport, sharing stories. My sister is 37 weeks pregnant now. I gave her the Abrysvo vaccine. So when they ask, oh, what would you do? I say, look, unfortunately, I was pregnant too long ago. I'm very old. But my sister, who's pregnant now, I gave it to her. And, this is what I would do to my family. Often they ask the next question, oh, do you like your family? But no, honestly, this is what I do, and this is what I would recommend, hand over heart, and this is what I've done. So sharing stories like that can be powerful, but really listening and going, you and I want the same things. We want you and your baby to be healthy. Can you share with me why you've got concerns? What are they? Let's listen to them. Let's see if we can unpick them. And planting those seeds, even if it's not now, if it's not this visit. I've had somebody who refused a flu vaccine for about 12 years. I almost fell off my chair when she said, I'm going to take it this year. So build that trust, build that rapport, really be curious and ask why. And sometimes you'll be very surprised, how they answer. But when they feel heard and they feel trusted, it really opens up a wonderful conversation.
yeah, I think that's a really good point there. Actually, we have to allow them to ask their questions and feel confident and listen. So, I think there's a couple of questions that have come up around revaccination. So definitely for infants who, say in Queensland or WA, who have high risk, are a high risk group, and including Aboriginal Torres Strait Islander children in WA certainly, giving a second dose the next year is fine. The antibody will have gone out of the system by then. It lasts for up to 5 or 6 months. But after that, they certainly are able to have an. In fact, in tropical WA, some infants are having 3 doses because they're had one at birth, then one 6 months later, and then another one before the next RSV season. So, and certainly there's been no issues with safety. So really important that safety is for both maternal vaccination and for Beyfortus have been demonstrated to be very good. Multiple pregnancies. So
before you move on, just a
Yes.
practice tip with the Beyfortus between
yes.
dose number 1, 2, 3, as long as there's a minimum of 6 months, it's not dangerous, but it's just to make, we know that it's probably likely to give protection for a good 5 to 6 months. So hence the recommendation to space apart by at least 6 months to make sure we're making the best use of our resources.
Yeah, fantastic. That's great. And I can't believe there's any mother who's having a second pregnancy already, but people are getting worried about it. So revaccinating somebody, a pregnant mum in a second pregnancy. Sarah, do you want to answer that one?
I think there's more studies coming out, but it's not currently in the guidelines, and it's more of a watch this space. But I think the general feeling is it's likely to be a recommendation for each pregnancy if we look at how pertussis, maternal vaccination, works. And I guess if we extrapolate, that would be my feeling, but watch this space for the official recommendations. So currently it's on all the guidelines, TAGI, ANSWERS, Australian Immunisation Handbook, it basically says watch this space.
Yeah. That's right. So I think that's really important. But like pertussis, we probably will go down that path, I imagine, because that's how you'll optimise that passive transfer of antibody. So so I think we've answered most of the questions now. Actually, it's getting close to time. Second multiple pregnancies we've answered, and I think we've addressed as much as we can the ordering issue. That's pretty. There was somebody who asked, is 1 ml dose too big to give to a baby if they're just over 5 kilos into their thigh? Does anyone want to take that? Priscilla?
Sorry, no, well, if that's the recommendation over 5 kilos, that's the recommendation over 5 kilos.
Yeah, no, and to be honest,
it's not that much.
No, that's right. And certainly that's the case. We have, because I think people may not be aware, but actually the palivizumab that was given to high-risk infants previously, in fact, you calculated the amount that you could give, and 1 ml was frequently the dose given, and really no problems giving it, even in ex-preterm babies. So certainly 1 ml fits into a baby's thigh. So, and having a cough, is that a contraindication to giving the immunisation? No, I think we've covered that. So
I guess there's a couple of comments about making this distinction between maternal vaccination and passive immunization with a monoclonal antibody. I think whatever works for you, the patient, and their understanding, and if it fits, I think absolutely it's true. Sometimes for my patients, if they're asking about the differences, what's the difference between this Abrysvo that we give to the mum with the active maternal vaccination? How is this different to monoclonal antibodies? Because it sounds like a scary name. Is it anything to do with mRNA vaccine? So normally we make that distinction, and sometimes I'll just tell them it's sort of like mum making the home cooked meal. It's it's all pre-made for you. It's like takeaway. The baby immunization, it's all done there. It's all packaged and ready to go. And the maternal vaccination is almost like a Hello Fresh or Marley Spoon. There's some of the ingredients in the recipe there. You've got to do a bit more fiddling around, but either way, the baby will be protected, and they work differently. So use whatever analogy and whatever the patient sort of connects with.
Fantastic. That's great. So look, I think we're almost at time now. So perhaps one or two take-home messages. Leon, do you want to start us off?
Yeah, just 2 words: be opportunistic. Take every opportunity to find every mother and every baby and talk to them and have a conversation.
Fantastic. Thanks. Priscilla?
Yeah, just remember to consider all immunisation providers from all different avenues. So, we've got midwives, we've got primary care workers, we've got GPs, antenatal clinics, paediatricians, obstetricians. Together, I think we can get that herd immunity. And so, yeah, let's just all work together and work to get our patients immunised.
Fantastic. Thanks. Sarah?
I'm a bit greedy. I've got 3 take-home messages. One,
Okay.
I'll relink the RSV diseases resources that the Immunisation Coalition has put together. It's a wonderful one-stop shop. The second take-home message is that you matter. Our healthcare provider recommendation is the most important determinant of whether they will take up that vaccine. And a single one-line sentence usually gets 3/4 of my patients over the line. They'll go, okay. And the third take-home message is in terms of reducing the chance of errors, RSV, Rex, the older patient, Abrysvo, AB, whether it's antenatal baby, Abrysvo for the bump or belly, whatever works for you. And the third one, Beyfortus, it's like building a fort to protect the baby. And thank you for sharing some of the other memory hooks that you found helpful. So they're probably my take-home messages to, 1, reduce errors. Your recommendation is important, and there's some fantastic resources that the Immunisation Coalition has put together. Thank you.
Fantastic. Thank you, Sarah. And so just from my point of view, as a paediatrician, by vaccinating babies, you will keep them out of hospital, and also your general practices as well, for those of you working in general practice. So we can actually decrease the impact on hospitals and health services by providing immunisations. And picking up Priscilla's point, this is everyone's responsibility. So thank you, everyone, for joining us tonight. And I think I'd like to thank all the 3 panel members, Sarah, Leon, Priscilla, for their excellent advice and wisdom that they provide us. And thank you, the audience, for being so engaged and asking all those questions and also providing quite a few answers. So that was great to see as well. Remember, this webinar has been recorded and will be available on the Immunisation Coalition website in about a week's time. And you'll also be able to find future education events about immunisation on the website. And please, we would like to know how we can improve these webinars to provide information to you as immunisation providers. So please answer the small evaluation survey and provide any feedback, perhaps what you'd like to hear about next time. So thank you, everyone. And I hope you have a good evening and that we can together reduce the burden of RSV in young babies in Australia. Thank you, everyone.